Hello, everyone. This is Isaac Georgy,
And this is Shady Faltaous.
and here we're presenting a case vignette of pancreatic malignancy as a potential cause of spontaneous cystic artery bleed. Just as an introduction, spontaneous cystic artery bleeds as a cause of hemoperitoneum are extremely rare. When they do occur, they're most commonly due to arterial malformations such as a pseudoaneurysm. Here we present a case vignette of a patient who's 66 years old with a past medical history significant for alcoholic cirrhosis, heart failure with preserved ejection fraction, and atrial fibrillation, who presented as an outside transfer with a chief complaint of abdominal pain, jaundice, decreased appetite, and increased fatigue. After presenting to the emergency department, the patient endorsed lightheadedness, fatigue, clamminess, and was found to be hypotensive. Pertinent labs for the patient included a hemoglobin of 7.8 that downtrended to 6.3 after several hours, an elevated white count at 24.4, an elevated lactate of 5.7, an elevated lipase of 210, and an elevated direct bilirubin of 13.8. The patient then underwent a CT angiogram that demonstrated hemoperitoneum and a large hematoma in the gallbladder lumen with active contrast extravasation, suggestive of an active bleed. Additional findings that were pertinent to the case was a lesion on the uncinate process of the pancreas that was suspicious for pancreatic malignancy. Unfortunately, this patient had to undergo massive transfusion protocol to deal with the hemorrhagic shock that she was suffering from. The patient then underwent emergent IR embolization for the suspected cystic artery bleed. Angiography during the IR embolization further confirmed active contrast extravasation. Because of the patient's picture of an elevated direct bilirubinemia, jaundice, and CT findings of a lesion on the pancreas, an ERCP was performed that revealed a stricture of the common bile duct, and brushings were performed that revealed atypical cells. Additionally, the tumor marker CA19-9 was elevated at 3,614, all supporting the diagnosis of pancreatic malignancy. And here we speculate if this pancreatic malignancy played a role in the patient's bleed and hemorrhagic shock.
Thank you, Isaac. And in the middle of the presentation, I want to turn your attention to the top left image that shows the axial 3 millimeter scan. And this image demonstrates at the blue arrow a 21 by 17 millimeter cystic lesion on the uncinate process that was suspicious for a pancreatic malignancy, such as IPMN. The image right below it is fluoroscopy findings of active contrast extravasation at the red arrow. Here you can see the cystic artery arising from the the right hepatic artery, and the branches of that showing active contrast extravasation at the red arrow. Additionally, the coronal 5 millimeter arterial phase further demonstrates active contrast extravasation with a large gallbladder wall hematoma, and this is demonstrated at the orange arrow. So in conclusion, the severe cystic artery bleed and hemorrhagic shock is of undetermined etiology, and we suspect that pancreatic malignancy may have played a role. As Isaac mentioned, spontaneous cystic artery bleeds are extremely rare, and most of the time they are due to arterial malformations such as pseudoaneurysm. And so we recognize that, this is a unique patient presentation, and that our patient also had several additional clinical factors, including anticoagulation that and also their cirrhosis that may have exacerbated the extent of the bleeding. Nevertheless, this is a interesting case of a spontaneous cystic artery bleed that we suspect may be due to a pancreatic malignancy. Thank you.